We are here with Drs. Binmoeller and Bott to discuss their paper entitled EUS-guided treatment of gastric fundal varices with combined injection of coils and cyanoacrylate glue, a large U.S. experience over 6 years. Dr. Bott is the first author and Dr. Binmoeller is the senior author. Dr. Binmoeller, you developed this technique of EUS-guided combined coil and glue treatment of varices and reported your pilot experience in 30 patients in 2013. Before we discuss the current paper, can you please explain what inspired you to develop this approach?
Yeah, I've been using glue to treat gastric varices for several decades now, and any endoscopist who uses glue long enough will encounter embolization. It is the most serious and most feared complication of glue injection. In my personal case, I had one patient who had a patent foraminovalle, and the glue got into the arterial system to the brain, and the patient had a stroke with subsequent hemiparalysis. What I hypothesize is that if we place a coil before we inject the glue, the coil can act as a scaffold to retain the glue, to bind the glue, and prevent the glue from embolizing, from flowing away with the blood flow. The synthetic wool fibers of the coil will retain the glue, and there may be some additional advantages in that the glue will be more concentrated in at the target site, in the varix, and the coil itself may contribute to varix obliteration.
How about just using coils and eliminating glue altogether?
Yes, actually that's been done, and it's been reported with very good results. And I think that's a very viable option. The only drawback I see is really more of a practical one. You have to deploy a lot of coils to achieve varix obliteration, sometimes in excess of 10 coils. So I think a more practical strategy, we don't want to throw out, as they say, the baby with the bathwater. I think glue is very effective, right? And it's been used now for decades with great results. The issue is the embolization. If we can eliminate that risk, then I think we're all going to breathe and sleep easier using glue. And so this may be the solution, using the coil first.
So why EUS-guided as opposed to conventional endoscopy guided?
Yeah, well, in this case, it has to do with the coil, because if you deploy the coil blindly, if you will, just under endoscopic guidance, then that coil could get into the interstitial space. It may not be deployed in the varix itself. So you need that confirmation. So maybe you could use fluoroscopy. That might be an alternative way of doing it. But I think you need some additional visual guidance as to where your coil is being deployed. So that's really the main reason. But I think as endosonographers, we just prefer to see the target, just like pseudocyst drainage, right? We prefer to be able to see the pseudocyst, even though you may have some bulging and there's a pseudocyst there. So we just prefer endosonography guided treatment if that's an option. So I think for this specific strategy, you need it because of the coil, and if you could deploy the coil under fluoroscopic guidance, for example, I think that would be reasonable.
Dr. Bott, let's turn to the current paper. What does the current paper add to the earlier pilot experience in 30 patients reported in 2013?
Good question. Several things. I think firstly, we've increased the number of patients from 30, which was at that time a pilot experience, to now 150 patients, which anybody who's aware of this is a large number of patients with this disease to be treated with coil and glue. Really, this will be the largest experience of this nature. Secondly, we were very meticulous in keeping records for all these patients, and we have now a follow-up this is an experience over 6 years with a mean follow-up of 436 days, so over a year follow-up per patient. Thirdly, we also added patients for primary prophylaxis as our experience grew which we did not have in the initial paper. So we chose patients with large varices at risk for bleeding, typically varices greater than 2 centimeters. And as we started treating them, we enrolled that as well. So all of those are things that we've added to this paper from before.
Did the long-term results validate your pilot experience?
Yeah, the long-term results have certainly been very encouraging. We had a follow-up in 125 patients, and of those 150, and those are the ones we sub-analyzed. And of those, 100 patients had endoscopic ultrasound follow-up, clearly looking at perforator vessels or submucosal varices, etc. And in those patients, we had a obliteration rate of over 93%, which is really very good for this group of patients. Among those patients that had complete obliteration, the bleeding rate was only 3%, and those patients were treated again with EUS-guided treatment and had great results. So overall, we felt that this strategy has been highly effective and successful in the treatment of these difficult lesions. The other results that we are very happy to report are the results in the primary prophylaxis group, because this was a subgroup of patients that in the past would not be candidates for endoscopic treatment. But in that subgroup, we had 96% obliteration rate, and 80% of these patients were able to have complete eradication of the varices with just one EUS-guided treatment.
I might just add that our hepatologists have fully embraced coil and glue treatment or endoscopic treatment of gastric varices as the approach of choice. So our patients are no longer evaluated for TIPS. Of course, early on, we did require that patients be evaluated for TIPS, and we only included those patients who were considered to be poor candidates for TIPS. This has now changed. The hepatologists now have embraced this as the approach of choice, and so they are no longer sending the patients for TIPS evaluation. And in addition, our hepatologists have also fully endorsed prophylactic treatment, having reviewed our results for prophylactic therapy. So I think this is also a unique aspect of this study. It's the first look at prophylactic treatment using this strategy for large gastric varices.
How about adverse events? Was there any embolization?
Well, we had one patient of the 152 who presented 1 week after treatment, so not immediately, but a week after, to the ER with fever, shortness of breath, and in cross-sectional imaging, there was a suspicion, though never definite confirmation of embolization, pulmonary embolization. We debated this because it wasn't classic for post-glue injection embolization, which usually happens within the first 24 to 48 hours. This was a week later, where the patient was discharged home, presented back. But because there was an element of doubt, we decided to include that and report that as an embolization, so that it is in the published literature. But other than that, we did not experience any embolization events.
And because we don't mix the glue with a contrast medium like Lipiodol, there was no way for us to really evaluate whether the glue had indeed embolized or not.
Is a randomized glue versus coil glue trial on the radar?
It needs to be done, but it's going to require a large number of patients to prove that this approach results in a significantly greater safety profile. So yes, we need that trial. It needs to be multi-center, and it needs to be properly powered. In the case of our institution, I'm obviously very biased in favor of this approach, and our results have been excellent. And really, with the exception of this one case of this delayed pulmonary embolus that I'm not really certain was due to glue embolization, we haven't seen this complication. And that's, of course, for me, very gratifying. So yes, I look forward and hopefully this paper will inspire other centers to try this approach and consider a randomized trial.